Hi, good morning, everyone. We are live for 146th CMAAO International Weekly Session. We are meeting on 10th of June 2023, and it's 9:30 a.m. in Indian Standard Time. This is a special session for all the medical associations of Asia and Oceania. I welcome all the associations over here to be a part of it, and all the members can see this forum online as well. Today we have Dr. Milind Shah. He's talking about hypertensive disorder in pregnancy. He's a naval material nurse, home, sperm bank and infinity center doctor, and he's based out of Mumbai. And sir, over to you. And I would love to have your presentation from have your introduction from your mouth.
Great. Yeah. Thank you very much, Saurabh, for these kind words. In fact, I was amazed, when I got this invitation from Nishita, I thought what actually this CMAAO is, because I was not knowing about it. I was not knowing much about actually the organizations which are going to join, though I work extensively in the Asia Oceania region for a variety of reasons and ranges of FOXC and ranges of FAOPS, that is Asia Oceania Federation of Perinatal Societies, where we had been to, try to see that the mortality and the morbidity in the mothers and the babies should go low actually as far as possible. I will just share my presentation while I'm speaking, so it will be, it is clinical guidelines. Yeah.
Thank you for joining on your travel. I just want to thank you for joining from a petrol pump. This is the first time you're doing a presentation from a petrol pump.
Yes. In fact, I'm traveling there to Nasik because we have actually the state conference whereby I'm going to speak on the contraception in the special situation. And then I thought, I must not miss the chance to meet all my friends from the Asia Oceania region, whereby I know there is a need of a lot of things as far as the medical knowledge, awareness, as well as the disseminating that knowledge is concerned. I remember before pandemic, we started a perinatal chapter in Afghanistan, and I realized that the maximum mortality as far as the mothers and babies is concerned in that country. That time the country was quite silent, and it was the invitation by the health ministry of Afghanistan. So we went very safely, came back very safely. But that always created me more interest in our region of Asia Oceania. That is, there are these countries where we need to do a lot of work together to help our mothers as well as the babies. I hope my presentation is running well. Can you see my CV slide?
So we can see.
You can see that, yeah. Okay, great, yeah. Now see, as I told you, I had a fortunate enough to visit all these various countries, not only in our continent, but also in the other continents in the West as well as the South America, where I realized the problems are similar. Only thing the presentation is different, and we need to always and always come together to exchange our knowledge, to understand each other, to know that what new we can do for that particular country to save our babies and to save our actual women. And that's how actually I accepted this invitation by Saurav and the entire group of CMAAO as well as the Heart Care Foundation of India. I must say big thanks to both of them, especially the chairman of the CMAAO, Dr. Wong, as well as Dr. Kazi, who's very much here, and all those infos taken by Saurabh as well as Nishita. This hypertensive disorders in pregnancy is very close to my heart because I came out with this particular book, the title, Hypertensive Disorders in Pregnancy, the first monogram of Indian scenario. and eventually it became an international edition, because whenever I went to FIGO, that is our federation, which is international, all those conferences, they translated this particular book in various languages to understand people that yes, these are the things in the countries which probably may not be seen in the Western world. And that's why we thought that all those experiences, suppose we gather collectively, we can do a lot of things together and we can do certain changes in that particular aspect of management. We know that as far as this HDPs are concerned, there are clinical guidelines which are systematically actually developed, which assist clinician as well as the patient in making decisions about the appropriate treatment for specific conditions. And that's how even the HDP has also evolved a lot, because we understood that there are actually certain things which are different in different scenario, different countries, and one must be evaluated with the reference to the individual patient needs, individual resources, limitations, the variations in the local populations. And it is hoped that this process of local ownership will help to incorporate these guidelines into a routine practice to come as a good outcome as far as the health of the mother and baby is concerned. The attention is drawn to areas of clinical uncertainty where further research may be required. And that is the problem with medical field, because we know that in medicine, it is not always 2 plus 2 is 4. Sometimes we see that 2 plus 2 is 3 as well as 2 plus 2 is 5 as well. And that's why we need to discuss a lot. Now, there are actually the evidence-based era, what we say about, and we have certain actually the standards which have been developed, whereby we have a category A, category B, category C evidences whenever we deal with any particular condition in the medicine. And that's how we always feel that the research always puts more light as far as the management of that particular condition is concerned. But all said and done, the good practice points are always of rescue to many clinicians, because they always and always find that these practice points are more important. So whenever I speak either in India or any other country, always give thrust on what I do in my clinic, and probably many people they take it in very positive note, saying that yes, doctor, we understood that these are the things which can now be incorporated, and then we inculcate more and more research for that particular intervention, and that also goes a long way when it comes to the outcome of that particular condition is concerned. Same is applicable for the hypertensive disorders in pregnancies as well. These guidelines or the recommendations for the management of HDP are typically written for the implementation in the ideal setting. But we know that all countries which are getting actually the join for this particular webinar know that these ideal conditions are not always and always there available. It is acknowledged that in many parts of the world, it will not be possible to adopt all of these recommendations. All units managing hypertensive pregnant women should maintain and review uniform departmental management protocols and conduct regular audits of maternal and fetal outcomes. Now, these are responsible for significant maternal and perinatal morbidity as well as mortality. And you can see here that they complicate almost 10 to 17% of pregnancies. Approximately 2 to 3% of these cases lead to hypertensive crisis. We used to call them previously pregnancy-induced hypertension or the PIH. But we realized the varied actual pathology as well as the pathogenesis of this condition, and this terminology has now outgone, and we now started calling it as a HDP. It is second leading cause of maternal mortality after postpartum hemorrhage. And that's why we need to have a certain good actually the practices as well as the drills to manage this particular condition. It is responsible for almost 17% of the maternal death in India as well, which is my own country. It is important cause of bad obstetric outcome. It has a varied and incompletely understood etiology. Here we know that all systems of body get involved, and that's where the challenge for the clinician is more. It requires close monitoring of the mother and the fetus. Hospital management preferred in severe cases, and prognosis has improved with advances in the management. And what is most important is a team approach. Suppose we all come together, maybe OBGYN, physician, intensivist, neonatologist, pediatrician, the nurses, midwives, they come together for this noble cause. Quite often we find all those success stories which we see in our actually clinic as well. We know it is a disease of many theories, known from centuries back. This PIH is an enigmatic condition of pregnancy which can't predict, can't prevent, and can't treat absolutely. So, from definition to conclusion, only controversies and controversies. And that's why this challenges. It starts from the definition itself. It's too many definitions and too complicated definitions. The hypertension that develops de novo as a consequence of pregnancy after 20th week of pregnancy, returning to normal after 6 weeks of delivery was the conventional. It is present when diastolic is more than 90 and systolic BP is more than 140, or the systolic BP rises at least 30 millimeters of mercury over the baseline, or the diastolic rise of 15 millimeter of mercury over the baseline. We say that yes, she got HDP. Now, this HDP could be chronic hypertension as well, because sometimes they are hypertensive before pregnancy also. It could be a preeclampsia, that is, it develops during pregnancy. Suppose that patient puts convulsion, we call it as eclampsia. Sometimes this superimposed preeclampsia can be seen on the chronic hypertension, which is again more confusing. Or there could be an entity called gestational hypertension, which is transient hypertension, whereby the systemic involvement is not that grave, and there where the patients can very well come out of it. The definition which has been given by this International Society of Hypertensive Disorders is white coat hypertension, referred to elevated in the office BP more than 140 by 90, but normal BP measured at home or work. It is not an entirely benign condition, it conveys an increased risk of preeclampsia. It can deteriorate rapidly without warning as well, and we do not recommend classifying it as a mild or severe, because there is a particular condition, fulminating preeclampsia, whereby we see the patient is good when she comes today, and after 2 days she comes with a lot of swelling, lot of albuminuria, and very much raised hypertension with lot of systems involved. It may develop or be recognized for the first time in the intrapartum or early postpartum in some of the cases as well. And that's why only during antenatal care it is not carrying importance, but also during delivery and the postpartum period is also important. There are certain actually the conditions whereby the hemolysis, elevated liver enzymes, and low platelet syndrome, that is we call it HEP, which is a manifestation of severe preeclampsia and not a separate disorder, but unless and until intervened aptly at that particular moment, can lead to a lot of actually the problems for that particular patient. This is another actually the definition which again has a similar sort of groups, but more so actually the definitions are getting always and always revised by various organizations, because they wanted to understand the systemic involvement, because it is kidney, if it is the liver, it is the neurological complications or the hematological complications, all need to be actually understood properly whenever we are dealing with the case of preeclampsia. It carries actually many other organs as well, including the eye as well as the systems in the other system in the body. But more so, as an obstetrician, we again have a worry about the uteroplacental dysfunction as well, because it can cause fetal growth restriction, abnormal umbilical artery Doppler waveform, or even can cause stillbirth as well. And that's why one need to be very careful. Why we need to discuss it at a very extensive stage, because you can see here it is a comparison between the Western world and the Asia Oceania continent. Severe preeclampsia seen is 0.5% in the Western world, whereby 10 to 15% in the Asian or the Oceania continent. Why it is so? Quite few are women. They are at home. They are away from the antenatal services or the intrapartum services, and that's how quite often they come quite late when they get the severe preeclampsia or some of the complications of preeclampsia. When they put conversion, we say it's eclampsia. And you can see again the difference. It is 1 to 5% in our continent, where when the Western world is 0.05% because of the intervention which happens at apt time. The case fatality rate also differs, as you can see here, as well as the major complications. You can see here how they differ in the Western world and in our country. So, what is the cause or what is the primary effect of this particular condition is always and always a controversy. But eventually, we learn that it's an abnormal placentation due to inadequate trophoblastic invasion, and that's why this terminology previously used was the pregnancy-induced hypertension. But we have realized that some endothelial dysfunction with the associated vasospasm as well, and which has some genetic component behind it. And that's why, suppose a patient asks me anytime, why doctor, why it is only me that I got this rise in the BP during pregnancy? And sometimes I can now tell her that this could be because of this particular problem. As symptoms appear late, it is signs which need to be carefully elicited. One need to observe standard schedule for the antenatal examination. Meticulous and accurate blood pressure recording and weight measurement is required. Upward trend in the diastolic pressure, though in normal range, could be predictive of this pregnancy-induced hypertension or the HTP. Suppose it's rapid weight gain, presence of risk factors, we need to be very, very careful. Which are these risk factors? The parity, extremes of actually parity, sometimes in primary as well as multipara. The age, again the extremes of age where the HDP is commonly seen. Race is again it is seen in all races, but the actually communities which are actually in the are actually considered Asian or the Oceania country women are more prone for the preeclampsia. There is a familial tendency whereby if the mother got that, the daughter is also likely to get the preeclampsia. Antenatal care definitely matters. Whenever there is over distension like multiple pregnancy or hereditary hormone or fetal head drops, chances of preeclampsia are more. Undernutrition or the overnutrition is one of the risk factor. Chronic vascular or the renal disease, diabetes or the GDM, history of preeclampsia in previous pregnancy, all that matters as far as the risk factor is concerned. Immunological causes or the pregnancy after assisted reproduction also has the more chance of getting the preeclampsia. Now, question comes then all said and done, how one should assess the patient when she comes at the initial presentation. The classification of the severity is primarily based on the level of blood pressure and the presence of proteinuria. The clinician should be aware of potential involvement of other organs as well when assessing maternal risk, including placental disease with fetal manifestations. It is always and always necessary to have an involvement of senior obstetric and anesthetic staff and experienced midwives involvement, because we know that quite often is missed. I know certain stories which I have noticed that sometimes it causes suddenly the patient comes with a convulsion, and when we see the antenatal records, quite often there is some evidences of hypertension which is not got noticed by the junior staff. The senior obstetricians can definitely note it and do the interventions accordingly. The headache, epigastric pain, increased edema, tender reflexes, and O2 saturation on pulse oximeters are the things one need to monitor this particular condition. When it comes to the BP measurements, let me tell you, friends, that quite often there are errors in the BP measurement as well. How to keep the hand at the heart level is again very important aspect. Which position, the sitting, how actually one should notice. Those need to be taught to all our junior colleagues. The patient should be asked to relax at least for the 10 to 15 minutes. The measure the sitting posture in OPD and the semi-recumbent position of hospitalized patient. Left lateral position always gives false low values because we know actually how it keeps away the pressure of the gravitations on the major vessels. The cup should be of appropriate size and should be placed at the level of the heart. We know certain patients are quite obese, and that time that extra large cup is required. The small cup may overestimate blood pressure. For every 10 centimeter rise of BP apparatus above heart level and 7 millimeter of mercury of BP falls. Multiple readings should be used to confirm the diagnosis. And for diastolic blood pressure, the colleagues always get confused how to actually identify, because sometimes this doesn't stop abruptly. There may be the muffling sound. So it's very, very essential to use this Korotko 5 sound, which is considered the zero. Automated methods need to be used with cautious, but sometimes I find in my practice are quite useful, because though it has certain errors with the automated methods, it gives the prima facie a good idea, especially when my junior nurse is taking blood pressure. At least I can, have some sort of comparison how she's taking that. It is also essential to understand these changes in the blood pressure, that how it varies in the various time of the day. There is a nadir between 2 to 4 a.m., peak at 6 to 8 a.m. because endogenous steroids are at maximum concentration at that particular time. It remains stable during day and progressively falls during the evening and night. So this diurnal variation need to be understood. Similar is the case with the edema. We need to understand how actually we should take the edema, how we should place our finger on the medial malleolus to know that whether there is edema or no. And the proteinuria again is a very important aspect. Usual screening test is visual dipstick assessment. Ideally, a more accurate test, either a spot protein creatine ratio or 24-hour urine collection is required to confirm it, but may be cumbersome in all settings, especially the under-resourced settings. A ratio of more than 30 milligram per micromole is abnormal. In India, certain primary healthcare center, we do the boiling and the addition of acetic acid, friends. But when there is scarcity of this dipstick, actually, this sticks, it's a wonderful actually method which I find useful in clinics, whereby the any particular paramedical person can take actually this urine in test tube, and he or she can boil it to find out how that coagulum forms. And it has again a four actually sort of levels: 1 plus 2 plus 3 plus and 4 plus. And of course we add the acetic acid to that once that coagulum is formed, to segregate it from the proteins and the phosphates. The BP should be checked every 15 minutes when she's stabilized, especially in the cases where there's very high blood pressure and we are controlling it, and then every 30 minutes in the initial phase of assessment. It is checked 4 hourly if a conservative plan is in place and the woman is stable and asymptomatic. The assessment of the woman requires a full blood count, the liver function, renal function test, including uric acid, the latter being associated with the worst maternal and fetal outcomes. And this should be repeated at least weekly when the results are normal, but more often if the clinical condition changes. We call it as a pre-eclampsia profile. Friends, nowadays, all these major laboratories are at our doorstep. And so we can take advantage of that we can do all this testing very, very accurately when she comes for the initial assessment. The clotting studies are not required if the platelet count is normal, that is over 100. Close fluid balance with the charting of fluid input and output is essential. The catheter is advisable if the condition is acute in the especially immediate postpartum period, to know how much urine is getting poured from those particular kidneys who got insulted because of this hypertension. Then in acute settings, the initial admission test is very, very important. This gives an information of the fetal well-being at the time, but does not give any predictive information. But primarily, you can decide what you're going to do as far as the plan of the delivery is concerned. Women in labor with severe preeclampsia should have continuous electronic fetal monitoring. If conservative management is planned, then further assessment of the fetus with ultrasound measurement of fetal size, umbilical artery Doppler, and the liquor volume should be undertaken. Serial assessment will allow timing of delivery to be optimized, and the value of the Doppler in other filter vessels is evolving. Is my voice very clear, Saurabh? It's absolutely okay at the other end.
Fine. It's perfectly fine.
Thank you very much, Saurabh. I just wanted to have a checklist in between. Now, when it comes to the prediction, which is again a very challenge because everyone then says, suppose we can predict it well, we'll be able to then decide of certain information. And you will find a number of actually the tests were tried, the rollover test, the Gantt and all observe that increase of more than 20 millimeter diastolic pressure when a woman is turned from left lateral to the supine position between 28 to 30 weeks of pregnancy. However, a high false positive reporting and the low reproducibility of the same woman makes this screening test of low reliability. The angiotensin 2 infusion test, which is very cumbersome, invasive and risky, not practiced. The hand grip test, it represents sympathetic nervous system activity, which is not the reason for the generalized vasoconstriction. A rise of 20 millimeter of mercury diastolic pressure is considered a positive test. The radioimmunoassay is again very cumbersome, expensive, and not feasible in every setup. The serum uric acid rise 4 weeks before the onset of PIH, and that's why one need to definitely assess that if you're suspecting that. Calcium creatinine ratio in the urine is also considered as a predictive test. With a lower calcium excretion in preeclampsia, it has a sensitivity of 70% and specificity of 95%. And the calcium creatinine ratio of less than 0.04 is significant. Maternal plasma endothelin 1 level in early pregnancy is predictive in 55% of the cases. The best method is to do the Doppler flow velocimetry. It is used to study the blood flow in the uterine artery, umbilical artery, and the middle cerebral artery. The criteria used are the SD, that is systolic diastolic velocity ratio, or the resistance index and the pulsatility index. This has a low predictive actually value as far as the IUGR is concerned. The poor biophysical profile as well. The ultrasound scan is second trimester shows bilateral notching of the uterine artery in a woman at high risk of developing PIH in 80% of the cases, with false positive rate of only 5% at 24 weeks. Bilateral notching of the uterine artery in early pregnancy suggests that impending preeclampsia is likely to be there. Doppler, it is now the boon for the prediction, so that in the mother clinician can be watchful and preventive treatment can be commenced early, and intervention and plan of delivery can be decided accordingly. There is a conversion of the spiral arteries into uteroplacental arteries. Diameter of the spiral arteries increases from 15 to 20 micro-m to 300 to 500 micro-m, thus reducing the impedance to blood flow. Pathological changes in the preeclampsia include inadequate vascular response to the placentation. It is very, very essential to insonate this particular artery, uterine artery properly, but when it crosses over the external iliac artery in the vein above the inguinal ligament. So we train our people to do so, and then the changes from high resistance vessel to one of the more diastolic notches into low resistance vessel with no notching, and the good diastolic flow, which we always explain them how it appears. The disappearance of the notch will happen first in the uterine artery that is directly under the placenta. If the notch has not been lost by 24 to 26 weeks, the woman is likely to develop hypertensive disorder preeclampsia. In pregnancies complicated by preeclampsia, notch persists due to impedance to flow, and persistence of the notch is the manifestation of angiospasm. This is how the notching looks like, as you can see in this particular picture, and one need to understand that. Now, there are many other substances which we call serum marker, which have been tried like fibronectin label, beta, human chorionic gonadotrophin, human placental lactogen, maternal serum inhibin A, and almost 160 such substances have been shown to be increased in the women with preeclampsia. But all these studies are conflicting. Nowadays, we are using actually this particular markers with effective actually prediction when we combine all these things together. Because now with availability of various softwares, we incorporate the serum markers we include are actually the findings of the Doppler studies in one software, where ethnicity, the age, as well as the duration of pregnancy is put in that particular software. And then we can actually diagnose almost 34% of the pregnancy that develop preeclampsia with 5% false positive rate. The accuracy has become more and more actually in the number, which is almost detection rate goes to 96% when we use this pulsatility index in both uterine arteries and the measurement of PAP-A and PIGF, whereby the all these actually the parameters we take into consideration together, we can definitely do actually the positive prediction about this particular condition, and the intervention accordingly, especially putting her on the aspirin or sometimes on the low molecular weight heparin can be done accordingly. The supplementation of the calcium, if the intake is likely to be low, because we understood that calcium has a major role to play as far as the development of preeclampsia is considered. It is not essential that each and every case we should give low molecular weight heparin, which is not indicated per se to prevent eclampsia unless the underlying cause actually says that it is required. The management of severe preeclampsia incorporates careful assessment, stabilization, continued monitoring, and delivery at the optimum time. Now, antihypertensive when to start is a big question mark. People always say one should not start it immediately because quite often it remains that way for longer duration. But again, it is a practical scenario whereby we see that if it crosses more than 50, 150 or diastole more than 100, we think of intervention. In women with other markers of potentially severe disease, the treatment can be considered at lower degrees of hypertension. Labetalol given orally or IV, nifedipine given orally or IV, or hydralazine can be used for the acute management of severe hypertension. In moderate, treatment may assist prolongation of pregnancy, but clinicians should use agents with which they are familiar, which are available in their particular countries. Also done, we understood that atenolol, AC inhibitors, angiotensin receptor blocking drugs, and diuretics should not be used during in the pregnancy because it affect the placental perfusion. Regardless of the hypertension disorder of pregnancy, BP consistently at or more than 140 by 90 in clinic or office should be treated, aiming for a target diastolic blood pressure of 85 in the office and systolic 110, 140. Antihypertensive drugs should be reduced or ceased with diastolic BP falls less than 80. Acceptable agents include oral methyl dopa, labetalol, oxyprenol, or nifedipine, and second and third line agents include the hydralazine or the prazosin. We understood that quite often it is not easy to get all those drugs available in every country. Now, when it comes to the seizures, how we can prevent the seizures, the convulsions, which is a very sort of the threatening sort of scenario for the doctors as well as the patient. Magnesium sulfate should be considered for women with preeclampsia for whom there is concern about the risk of eclampsia. This is usually in the context of severe preeclampsia once a delivery is made and in the immediate postpartum period. In women with less severe disease, the disease is less clear and will depend on individual case assessment. The principle of management should follow the basic principles of airway, breathing, and circulation. The magnesium sulfate is the therapy of choice to control seizures. Loading dose of 4 gram should be given by infusion pump over 5 to 10 minutes, followed by a further infusion of 1 gram per hour maintained for 24 hours after the last seizure. We call it the low maxal therapy. We know various regimens. The Pritchard and many others have given a wonderful regimens for our women, but every regimen has its own untoward effects as well. And that's why we prefer to use whatever is required for our own women, where the weight of that particular woman differs. The recurrent seizure should be treated with either further bolus of 2 gram magnesium sulfate or an increase in the infusion rate of 1.5 to 2 gram per hour. These are the various regimens which I was telling you about, which are there in my book as well. The Pritchard, the Kruzang Shank, Baba Sibhai, who has done a lot of work, Zusman, who has done a lot of work. But the last one which I told you about, is the low magnesium sulfate therapy, which we practice, which started actually in the practice in my country by none other than my own teacher. And she actually done extensive study on that particular thing. Now, the controlling seizure again has a more challenge apart from giving only magnesium sulfate. Sometimes we need to give the diazepam as well to stop the seizures. The secure airway, the placing the patient in the recovery position, facial oxygens are very important. If there is heart block or the myocardial infarction, that is a contraindication for the magnesium sulfate. One should start magnesium sulfate therapy, provide supportive therapy. Once seizures are controlled, blood pressure is sustained, and hypoxia corrected, delivery can expedited in the applicable cases. We should also think of alternative things as well, and there are heart block or the other contraindication. And there are many other things which are there actually can be used to control the seizure, which we can utilize. What is more important is turning the patient on one side, ensure clear airway, maintain the IV access, stop fits, control BP, intake and output chart, good investigations, monitor patients and feeders, and after stabilization, deliver the patients, which is again very important. Give me 1 second. Yeah. Hi, I'm sorry for this little disturbance. But now, how should fluid balance be managed? That is very important. Fluid restrictions are advisable to reduce the risk of fluid overload in the intrapartum or the postpartum periods. In usual circumstances, total fluid should be limited to 80 millimeter per hour or the 1 ml per kg per hour. Never neglect those alarming signs, and it will save a life of you. And that's why one need to think a lot about that. Impending eclampsia, as I told you, all these risk factors need to be again and again put as a thrust to all actually our patients as well as to our clinical staff, including nurses. And suppose they understand that, they can stop that. The risk assessment, readiness, response prevention is very important actually when it comes to the severe eclampsia. It has to be managed very seriously if the BP is more than 160 by 110, because it can happen even during the even postnatal period as well. And the drug which we are going to use again should actually have all these elements incorporated in that. But always and always say that getting that ideal drug for a given condition is not that easy. And that's why one need to see that it is properly utilized by a team which they are familiar with. The first line medication always is intravenous labetalol or intravenous hatrelazine, because they are a drug of choice and easily available in majority of the countries, whereby we can utilize them to stabilize blood pressure. It is essential that to understand magnesium sulfate is not as an hypertensive agent, though there is some sort of effect whereby we get slightly reduced blood pressure, but it is more so for the prevention of the convulsions. And that's why controlling seizures, the magnesium sulfate should be the first drug of choice. Unless contraindication should be given when managing hypertensive crisis, because there is every probability that she or that patient may get convulsion. Now, this is a flow chart which is given by the American College of Obstetrician and Gynecologists, how to stabilize blood pressure when she comes with the hypertensive crisis. I'm not going to read that in very much detail because I understand only now 10 minutes are left with me and we need to cover so many other things as well. But those who are interested, you can very well go to the stream of this particular webinar eventually on YouTube or the Facebook, and you can very well take the snapshots of this particular flow charts, or they are easily available on the internet as well for your references. It is essential that these drugs need to be used with a lot of caution as well, because sudden hypotension is again not indicated when there is babies alive. And that's why this oral nifedipine used with caution, because we know that sometimes we don't have control on that, whereby other drugs, when we are giving intravenous, we can at least stop them or withhold them immediately, whereby when it is given that way, it is not possible to take it back. It is very essential to see that sublingual use, which was once upon a time was very commonly done for the nifedipine, is absolutely outgone now, because it suddenly reduces blood pressure and can cause more actually harm to that particular patient. If the patient fails to respond to first line agents, recommend its emergency consultation with maternal and fetal medicine consultant, internal medicine consultant, anesthesiology, or the critical care consultant as well. How to then monitor that? One need to see that the blood pressure should be seen every 10 minutes during the administration of this agent, and once it is stabilized, every 10 minutes for 1 hour, every 15 minutes for next hour, and every 30 minutes for next hour, every hour for 4 hours. One need to see that this baseline lab is immediately sent, and the fetal surveillance doesn't need much emphasis. When the patient is stabilized, then consider about other things like controlling her actually the seizures also simultaneously with the help of other drugs like lorazepam, diazepam, or the phenytoin. Antenatal corticosteroids if the pregnancy is less than 34 weeks of gestation of the permanent maturity, because then we get some breathing time and we can then think of delivery. It's essential whenever possible to the fundoscopy, which should be part of your investigative approach, because again it causes a lot of insult as well as the uh, uh, retina is concerned. It is said by Pritchard long back in 1978 that in some mysterious way, the presence of chronic villi in certain women incites vasospasm or hypertension. Moreover, to effect a cure, the chorionic villi must be expelled or surgically removed. That means one need to take out that placenta, and that's why the delivery is very important. So once they reach the 37 weeks of gestation, and if they develop any one of the following actual things which we have seen now, especially the seizures, pulmonary edema, progressive thrombocytopenia, or the renal or liver enzyme tests are getting deteriorated, abnormal neurological features like intractable headache or the scotomas or convulsions, then there is the immediately intimation of delivery need to be considered. There is no reassuring fetal status. Again, one need to think about combination in view of the baby's survival. Now, how and when the baby should be delivered? Decision should be taken once the woman is stable and the woman is less than 34 weeks. Think of actually the corticosteroids, and a benefit of conservative management should be reassessed before taking this decision. The neuroprotection, if the gestation is less than 32 weeks, conservative management at very early gestation may improve the perinatal outcome, but must be carefully balanced with the maternal well-being as well. We always say that if the mother is good and stable, eventually she can deliver actually a few more babies. But suppose something goes wrong with her, then just looking at the baby is not that essential. What is required is to have all risk benefit ratio whenever you're taking any particular decision. The mode of delivery should be determined after considering the presentation of the fetus and the fetal condition, together with the likelihood of success of induction of labor after assessment of cervix, as we normally do. The third stage should be managed with 10 units of oxytocin. Ergometrin we don't use because it increases blood pressure again. The aim is the chronic care program aim is to prevention of the convulsions, evaluation of the mother and fetus, and timely delivery, and that can be done with all this information which we saw just now. But the monitoring is very important, which has to be done at regular interval if you are thinking of continuation of the pregnancy. The clinician should be aware of the risk of late seizures as well, and that's why the postpartum period is also very important. Persisting hypertension, proteinuria after 6 weeks may have renal disease and should be considered for the further investigations. You know that 44% of the eclampsia occur postpartum, especially at term. So one with signs and symptoms of preeclampsia should be carefully assessed. And that's why I remember in my older days, we used to say 3 stages of labor. Nowadays, they say the 4th stage of labor, stage of observation is again important. The antihypertensive therapy may be withdrawn over days, but slowly, not immediately. The NSAID for the postpartum analgesia should be avoided. It is especially important if they known to cause the renal disease or preeclampsia is associated with the placental abruption. And one should think of their kidneys as well. What one should take at the hospital discharge, that follow it regularly as far as the blood pressure is concerned. Preconceptional counseling should be offered where the event that occurred, any risk factor is there, one need to discuss, diagnose, and treat it accordingly. Risk of cardiovascular disease, lifestyle, and risk factor modification is very important, but it is essential that pre-pregnancy weight should be achieved by 12 months, and one should limit inter-pregnancy weight gain as well. These are the checklist criteria for the prognosis prediction. The persistent hypertension on the 10th postpartum day, 59% chance of recurrence. If weight and height ratio is more than 2.26 weeks postpartum, 70% chance of recurrence. And one third of the nulliparous eclamptic minimal level of hypertension in later pregnancies. As far as the prevention is concerned, there are many drugs again have been tried. The aspirin, the rationale is physiological balance between the prostacyclin and thromboxane A2 is of major importance in maintaining the vasodilated state of normal pregnancy, and whereby we know that in preeclampsia there is changes in the particular ratio leading to the problem. The calcium again has been found. The sincere preeclampsia involves endothelial dysfunction, and that's why oxidative stress need to be thought about with the help of antioxidants like vitamin C or E. Regular exercise may benefit by stimulation of placental growth and vascularity, reduction of oxidative stress, and exercise induced reversal of maternal inhibition. It is the emphasis should be on the correct BP recording, immediate and appropriate action if there is increased BP, and close vigilance of the various tests for the maternal and fetal well-being, and the timely intervention to avoid life-threatening complications. The principles of the management we just saw earlier as well. Most important is keeping all these things ready. The oxygen suction machine, equipments for the resuscitation, and the eclampsia kit whereby all drugs should be handy whenever they are required. And if at all there is certain things which are not manageable at your center, timely referral before patient goes or deteriorates. So friends, once again, I must say big thank you to the CMAAO as well as the Heart Care Foundation of India for giving this wonderful opportunity to interact with you. I'm very sure, though I tried to cover in it every aspect of this particular condition, there must be a lot of queries as well which you can put on various social media, and I'll be very happy to answer those particular actually queries very aptly. And thank you very much, Saurabh, for the patient listening as well as all that cooperation we extended for this particular talk, which was a little longer for more than 1 hour. But always call it as a master class, because you know, at one stretch, especially for the periphery colleges, when I give this, the students are very happy. Thank you, sir. Thanks a lot.
Thank you so much. I know there was little disturbance because you're in a public place. Dr. Shah has been traveling on the wheels, and he stopped by near the gas station and giving a presentation from the gas station. So I apologize from the audience, but I think I really thank him for being present on this and taking that pain of giving us knowledge and information about a wonderful topic. I have Dr. Chong, who is our chair. I have Dr. Wazi Kazi, who is the president of CMAAO. And it is a magic show where we start the show with 2 people and suddenly there are 15 people joining at the close-up presentation.
Yes. Hi, so, Dr. Chong. Nice to see you.
Dr. Chong, would you like to take the floor for the question answers?
Yes.
Thank you, Dr. Milind, for that wonderful presentation.
It's an indeed pleasure,
And preeclampsia is something we always really not on our minds, but definitely I myself had a couple of patients who had preeclampsia. We don't see them. In fact, I saw them after delivery, you know, when they were supposed to be well and so on. And on the 4th or 5th day, when they had gone home, and then I actually saw them with hypertension. And of course, you know, we had to refer them back to the gynecologist and to the maternity hospital here in Singapore. But certainly is something, you know, even you might come across, even though you're not an obstetric or gynecologist, you might still come across such an illness. And it can be devastating because, you know, you're talking about mom and child, you know, all at stake, you know, huge, it's a high stake game, I would say. And if you fail to pick up such cases, then not good at all.
True, it's a really a good actually comment, Dr. Chong, because the family physicians can play a major role. Because the first it starts from the family physician who detects that, and unless and until he is actually knowing the significance of it, that things can get deteriorate, and that's why always and always found that it is very important to have the involvement of family physicians. Even in my country, we always go to the periphery where we collect all family physicians, our colleagues go there, and we train them for this the pph or the preeclampsia and other conditions, so that the timely they are referred. Yeah, thank you.
Yeah. We always forget that a woman is still technically subject to complications of pregnancy up to 6 weeks post-delivery. We always forget that. And actually, that's something that we mustn't forget. And it's devastating because, this is you're talking about a very young woman who's otherwise very well. I mean, a woman who is very well, but subject to can be quite devastating complications of such
Yes.
post-delivery. So something that slips off our radar, and we always have to remember.
Yeah. We are starting another program whereby we are giving actually more importance now to even the mental health, the postpartum depression, again neglected topic. What happened recently? One of my patients, she delivered with me. She had traveled from US to my place, and eventually, when she got that, she could not realize it is related to the pregnancy or the delivery process. She went to psychiatrist, and then when she learned about this, she started a program. We are getting associated with her, so she is now right now based in US, and we are going to take it to all our Asia Oceania country. This program of postpartum depression. We want to create awareness for the women also, that how they can be managed with joint consultation of the physician, family physician, OBGYN, nurses, and the psychiatrist. Yeah. Thank you.
And coming back to this preeclampsia, I mean, the control of the blood pressure can be quite challenging. I sometimes have multiple drugs being used, and the pressure is still incredibly high. So it's quite a scary. A full-blown preeclampsia is actually a very, very scary event.
Yes.
And like I said, the stakes are very, very high. One interesting thing is this. Sorry, I'm a little bit out of touch, but magnesium seems to be very interesting. Is that endothelial dysfunction? Is that mainly to address the endothelial dysfunction?
Yes, the magnesium sulfate always and always useful for the seizures prevention. Previously what we used to do, we used to give a lot of sedatives, but these sedatives used to cause a lot of dysfunction of the other neurological functions as well, whereby this particular magnesium sulfate, the magnesium works at the cellular level, whereby we can prevent the convergence with avoiding lot of those untoward effects associated with the sedatives. That's why it has become a drug of choice now, and quite safe unless and until it is given in the proper regimen, which has to be again titrated according to the country scenario or the women's scenario, because the weight of the woman varies from country to country. So we cannot apply a rule of thumb. We'll have to defer as far as the dosage is concerned. That's how this idea of low maxal therapy for the Asian women came, where our women are comparatively short in height as well as the less in the weight. And even the low magnesium sulfate also is quite effective. And if it crosses more than actually the 9 or so, there's chance of getting the respiratory depression, which is again alarming. And that's why one need to be very careful. Yeah.
Interesting. I remember in the old days, they used sodium nitroprusside. Am I right?
Yes. That was one of the drugs which have been used. But nowadays, it is not because it causes trend relaxation as well and leading to another complication of PPH.
That's right.
True, very true.
Remember sodium nitroprusside a long time ago.
Yes.
Very interesting. And very interesting, I noticed the uterine artery notching. That's very interesting.
Yes.
Notching, is it a Doppler wave or is it
Yes, yeah, it is a Doppler. We'll have to insonate that particular vessel to understand that. And once we expert, like all our fetal medicine experts, now they give a lot of training as far as identifying that particular notch and how it disappears. And many clinicians are now getting trained for that particular thing. And that is one of the good predictor for the preeclampsia. whereby the intervention can be started. See, the aspirin is a wonderful drug per se, which can prevent a preeclampsia up to certain extent, but we cannot give it to each and every woman because we know it has some untoward effects as well. That's why we do this prediction and accordingly we do the intervention.
I see. And this notching, this Doppler finding
Yes,
that you'll see
it's Doppler finding. Yeah.
is linked to endothelial dysfunction as well?
Yes, it is associated with the endothelial dysfunction, and that's why one always correlate that with the prediction.
I see. Fascinating, fascinating. Wow. Preeclampsia has come a long way since sodium.
I know. Yes, very true. That's why we are coming out with the now second edition of my book of hypertension disorder, because we realize whatever we wrote that was few years before now again has a lot of changes in that. So we are going to incorporate that. And now this time I'm going to incorporate all my overseas actually the faculty also in that, so that I will take some lessons from other countries.
And in a country like India with a huge birth rate and a huge number of pregnancies, I mean, this problem can be quite a large problem, right?
Yes, very true. It's quite large problem.
Yeah. Any idea about in a year how many preeclampsia cases are there across the whole of India?
Actually, the exact figure actually cannot say, but it's now 10 to 20% per se at present. But we are coming out with a registry under aegis of our federation, whereby we want to have the registry of all those cases which are having preeclampsia or even eclampsia. But still, there is little apathy of the reporting also, and that's how sometimes we miss that, and we don't know the exact figure. But it's around in the range of 15% or 20% of the pregnancies.
Thank you. Thank you. Any questions from the floor for this wonderful presentation on a topic that a lot of us kind of have slipped off our radar?
Yeah. Good morning, Dr. Chong and Dr. Milan. Excellent presentation. In fact,
Thank you very much.
You have covered extensively on eclampsia. I have few comments and questions.
Yes.
But basically, antenatal care, where the urine dipstick, you pick up the albumin or protein and the blood pressure, that is crucial. In South Africa, we make sure every visit our antenatal clinic, urine dipstick and blood pressure must be recorded and done. And that's how you pick up early pre-eclamptic. The second point is why we don't see, or we don't see more in second pregnancy. If the mother had a first pregnancy eclampsia, second pregnancy, she is fine. So what is the rationale behind? And the last one is the eclamptic mom in a long term, is there any relation with the Alzheimer or memory disorientation cases? That's all my comment. Thank you.
Yeah, thank you very much, Dr. Akhtar. These are really wonderful actually questions. Coming to the first, yes, the antenatal care has a major role as far as the diagnosing those cases are concerned, and that's how almost all actually the routine clinics, they do the blood pressure measurement as well as the urine albumin assay. That's one part. Second thing about the second question, what you said about why they develop in one pregnancy and why not in other, that is always an enigma. We never understood. That's why we are putting a lot of research on that. Especially nowadays, we have realized there are certain genetic, actually the components which are involved in that. We want to identify that and we want to know about it as well. But per se, there is no answer to this particular scenario, why it happens only in particular pregnancy. Maybe something related to the nutrition as well, which may vary from pregnancy to pregnancy according to their family scenarios and other things. And coming to the last question, which you asked about is Alzheimer and the preeclampsia. Per se, I never came across any literature, but there is no any evidence which says that these are the women who are likely to get the Alzheimer in future life. But definitely we'll try to find literature on this particular aspect here.
Thank you. Thank you very much for that answer. Lovely. Any other questions from the floor? If not, yes, Dr. Kazi?
Oh, thank you very much, Chong. And thank you, Dr. Shah. It was wonderful, easy to understand, and cleared a lot of questions in our minds. And as you have pointed out, the antenatal care is so important and plays the key role in diagnosing the preeclampsia and then further on eclampsia. In Pakistan, the maternal
Yes, thank you very much, Dr. Vasu.
very high, and we do have high pregnancies over here, and 70% of our population lived in villages where our basic health units are not that functional. And as you know, in our part of the world, we call these, delivery women as dai. So these literacy plays another important role, and they don't go to for the antenatal care, and then when they end up with these complications, they rush on to a nearby hospital, and which is another issue, very difficult to reach there. That is the reason probably that we have a very high mortality rate, maternal mortality. So, these are the stigmas which still linger on. And what we need to do is definitely improve our basic health units, the primary health care services, and of course the importance of antenatal care, and then the hospital care that has to be there for every pregnant woman. Thank you, Shah, for your excellent presentation, and it was wonderful listening to you. And it was really easy to understand talk by you. Thank you very much. And thank you, Sarah, for bringing in Dr. Shah for such wonderful presentation. Thank you.
Thank you.
And without much further ado, I think we better let Dr. Shah go, because he's right in the middle of Tokyo somewhere.
Yes, yeah, because I need to speak on the contraception in special situation now after reaching Nasik. Yeah, thank you very much. Thank you.
Thank you very much for your
Thank
kind effort, and we much appreciate it. Thank you.
Thank you.
Thank you.
Thank you, everyone. See you again for